Hi all. Uh, so the topic that I'm going to discuss is belimumab in SLE, and so I'm going to discuss regarding definition and detection, treatment plan, discovery, development, and mechanism of action, and as well as I'm going to discuss regarding the key results of belimumab in treatment of SLE from the study paper and role of precision medicine and summary. So, in 50 years of span, belimumab was the first drug to be approved by the US FDA, and now going to what SLE is, it's an autoimmune disease which is linked to various factors such as genetical, environmental, hormonal, or certain medicines. It's also linked to de novo and inherited mutations. It's also considered to be an innate adaptive immune dysfunction that leads to chronic multisystemic inflammation. In simple terms, to lose the immune tolerance due to an unknown cause. SLE is detected with various diagnostic tools. It's like anti-nuclear antibody test, erythrocyte sedimentation test, and C-reactive proteins biopsies, complete blood count, urine analysis, metabolic panel, and imaging tests. When it comes to treatment options for the SLE, the standard of care always remains hydroxychloroquine, which is also an anti-malarial drug, glucocorticoids to reduce the symptoms, and if neither of the treatments can be tolerated, then we start with immunosuppressive agents such as methotrexate, azathioprine, mycophenolate, mofetil. Further, if patients are considered to have an early detection of organ damage, then IV cyclophosphamide. Uh, as per the Euro guidelines, SLE patients with residual disease can be started with biologics like rituximab and belimumab. Actual treatment plan differ from guidelines and standard of care remaining hydroxychloroquine, cyclophosphamide, initial IV pulse therapy with mycophenolate or low dose cyclophosphamide, and also patients with high risk of kidney failure, they start with high dose cyclophosphamide of 0.5 gram per meter square. As an alternative for patients with combination treatment with they do mycophenolate mofetil and tacrolimus for patients with proteinuria. Maintenance therapy for SLE, including mycophenolate azathioprine, is given in patients who are looking for pregnancy in future. For refractory diseases, rituximab is recommended as an along with the belimumab as an add-on. Uh, Now coming to the discovery and development and mechanism of action, first I would like to discuss regarding the mechanism of action. So belimumab is basically a BAFF, that is B cell activation factor inhibitor. It inhibits the binding towards the receptors, BAFF receptors, subsequently which are expressed on B and T cells, thereby decreasing the production of antibodies and interfering with the T cell function. So when we come to discovery, the main thing to be discussed was regarding turning point of like was that identification of B lymphocyte stimulator. Research was started by the Human Genome Sciences. They first identified this B lymphocyte stimulator and its characteristics within the body, how it impacts. And finally, they did certain studies and they identified the drug lymphocyte B, that is currently called as belimumab. Uh, BFF produces more kidney, making it a good candidate in lupus nephritis as well. So some of the key results which we noticed when I went through the paper was that the primary efficacy renal response and complete renal response was achieved by patients within the week of 104, and also they showed a decreased ratio of urinary protein to creatinine, and these are one of the like statistical data of the primary endpoint, primary efficacy renal response, and major secondary endpoints, and also this shows the biomarker specific endpoints as well. This one, it shows the patients with a response who are in belimumab and placebo. So when it goes to panel A, illustrates the primary efficacy renal responses. Panel B depicts the probability of PERR being maintained through week 104, who either discontinued or placebo, experienced treatment failure, withdraw from the disease, were not considered having had a response. Panel C responses presents the complete renal response over time. Panel D showed the likelihood of sustained CRR through week 104 with the discontinuation of belimumab or placebo. Treatment failure and or withdrawal with the trial counted as non-residual. The main key result was that patients achieved greater decrease in double-stranded DNA and C1q autoantibodies and greater increase in levels of complement C3 and C4. So these are the main key results that was identified from the study. When we talk about role of precision medicine in improving patient outcomes in response to belimumab, precision medicine helps the patient to selection based on the genetic profiling and assessing blast levels, helps in making individualized dosing during treatment based on genetics, and helps in reducing adverse reaction, helps in long-term disease management, and also enhances treatment of adherence and patient engagements by patient-centric approaches. Yeah, that's it. Thank you.